This is Waves, a podcast from APTA Michigan. I'm Andy Wicks. We've already spoken with some incredible physical therapists who work in the field of oncologic rehabilitation. It's a rapidly growing specialty area within physical therapy practice, with the first oncology specialist exam given in 2019. Currently, there are over 175 board-certified clinicians in the United States. Among that number is Adam Matichak. He practices at Stanford Healthcare in Palo Alto, California, and has a big heart for his patients. He also knows a lot of big words and long acronyms that have to do with oncology treatments. So, Adam, welcome to the podcast. Introduce yourself to the world however you see fit.
So my name is Adam Matichak. I am a acute care physical therapist at Stanford Healthcare in Palo Alto, California. My primary patient populations are hematology, oncology, bone marrow transplant, and then over the last 5-6 years, getting into more cell therapy and immunotherapy. So recently became a board certified oncology PT. So yeah, nice. Feather in the cap. But yeah, I kind of got into oncology rehab just like by chance. So we have to do an acute care rotation as part of our clinical rotations. And my clinical coordinator at school knew I was, born and raised in the Bay Area. And they said, "Hey, we have this spot at Stanford open. Do you want it?" I said, "Sure." Like, who wouldn't want to go do a clinical rotation at, a top 10 hospital in the country?
Yeah.
And so the way that their student program runs is you basically just get assigned to a CI and you just go work on whatever unit they are the primary on. So I ended up in oncology and bone marrow transplant and ended up kind of falling in love with it. And so that was my last rotation.
Okay.
And then when I first graduated, they weren't super keen on hiring fresh new grads. High acuity at the hospital, just a lot of like complex procedures, super complex patients. So they tended to, err towards more seasoned clinicians. So
Sure.
Started my career in outpatient ortho, was there for 6-7 months, and a spot on the BMT team opened up and they reached out to me and asked me if I wanted to come back. And I've been there ever since. So
look at that.
7.5 years later, here we are.
Here we are indeed. And I love it. You're actually not that I don't want to make you feel special, Adam, because you are very special. You are very special, but you are maybe the 5th oncologic clinical specialist we've had on the podcast, I think.
I was thinking that, like, we're really making the oncology rounds.
I know, pun intended. But I think it's awesome because when I was in school, I had no idea that PTs could work in the realm of oncology. It just wasn't even something that I don't even think it was ever brought up. And I didn't go to school that long ago where it's like, come on, it should have been a thing. But it's become, the more I learn about it, the more fascinated I am by it. And there's some super rad people in the realm of oncology PT that Adam, I know you know of, and I know we've talked about these people together that are just, there's some really, really cool people doing it. So yeah, just tell us more. Tell us more.
Yeah, we'll get to my soapbox later about how little education there is about oncology in the DPT curriculum. But yeah, I mean, same thing. Like I did not have any exposure to like anyone in my family having any major cancer diagnosis or hospitalization or anything like that. And so it was just like by chance, like I said, this is, where I got placed and, kind of fell in love with it. And there we go. But yeah, I mean, the really neat thing about oncology is that we get a little bit of everything, right? Like we get the acute care setting, we get the outpatient setting, we get, all the different side effects from chemo. We get cards, we get neuro, we get musculoskeletal issues. We get our super fit, I was triathlete, before I got my diagnosis. And now here I am. What can I continue to do to stay active while I'm going through treatment? Right. So we get like this huge spectrum of patients. And so it's always super exciting. There's always kind of something new going on. Being at Stanford, we do a ton of clinical trials, cutting edge treatments. So, kind of right at the tip of the spear as far as cancer care goes. And so we're learning a lot just like on the fly, which I think has been really cool because then I get to take all of that clinical experience that's just like trial by fire and share that with the rest of the oncology clinicians out there. So yeah, it's been a lot of fun just to, kind of always feel like a student, to always just be kind of learning something new and sharing information. And like you said, there's so many of these like rock star clinicians in oncology, and everyone seems to find their little niche. And so, right, like oncology itself is a niche, and then we have all these little niches within it. And so everyone kind of finds their little specialty and just,
So what's yours? What's your little specialty?
So mine is primarily bone marrow transplant and now cellular therapy. So we do what's called CAR T infusions. So here we go. We're going to go down this rabbit hole right away.
Let's do it. We're here for it. Let's do it.
Actually, that type of treatment is really topical in the state of Michigan. There was just a big thing that came out about one of the insurers here denying that treatment. Yeah.
Ooh.
But anyway, that's outside of the scope of this conversation.
So yeah, this is where cancer care gets really kind of science fiction-y, which I like about it. So CAR T cell therapy, chimeric antigen receptor T cell therapy. So
anything that's got chimeric in it, I'm totally on board for it.
And I love that they give us all these little acronyms, because otherwise it would take us an hour and a half to get through it. So, but anyways, it's basically taking a patient's T cells. And so these are autologous transplants. So the patient's getting their own cells back, but they're apheresing, and they're just taking out their T cells. And then they are sent off to a lab where they are now adding this surface antigen to the T cell. And then patient gets a little bit of chemo just to kind of knock down that immune response. And then they get this infusion of these now modified T cells that kind of go out and seek out their cancer cells and bind to them, can destroy them. So really neat. It's way more targeted than traditional chemotherapy, immunotherapy. We have a neat study that's going on right now where one of our docs is actually looking at biopsying the patient's tumor and seeing what type of surface receptor has the highest density. And then that's the antigen that they're using when they modify these T cells to make it even more targeted.
Makes sense.
So, yeah, the more targeted we can make cancer treatment, the less of these systemic side effects we have. So it becomes safer, we can help a wider range of patients with them. And so kind of the future of cancer care is, target like these ultra targeted therapies that don't have, this laundry list of side effects that we have to deal with for, weeks, months, years after they get treatment.
You're talking about the therapies becoming more targeted with the goal of, I think, being more effective, but you also talked about reducing side effects. So what side effects do you still typically see as a clinician? So your role as the physical therapist, what are the common laundry list of impairments that presents to you?
Yeah. So because these patients are still getting chemo before they come in for this infusion, we're still seeing a lot of the nausea, vomiting, cytopenias, so low platelet counts, anemia, low white counts, so high infection risk with this patient population. We're still seeing the peripheral neuropathies, some of the cardiac side effects from the chemotherapies. And then we add on a couple of really fun CAR T specific side effects. So we have cytokine release syndrome. So it's basically just like this overblown immune response. So see a lot of like high fevers, hypoxia, tachycardia, orthostatic hypotension. So a lot of those really fun, like acute side effects. And then we also have this other side effect that is called immune effector cell-associated neurotoxicity syndrome. And so they shortened it to ICANS for us to make it nice and simple. And so this is like a neurological side effect because these T cells are the patient's own cells. They can cross the blood-brain barrier. We can see cerebral edema, kind of spinal cord edema. And so we see, everything from like aphasia and confusion, word finding difficulties, all the way up to seizures and comas. And I think they've gotten a lot better at the medical management of these things. And so we're seeing less of those really severe side effects. We saw a little bit of it early on when we first started doing these, but I think the medical management has gotten a lot better.
I mean, my students have heard me rant on this from the semester, is that anytime you introduce edema into an enclosed central nervous system, it's very hard to predict what the impairments are going to be.
Yeah.
Because it's just, well, it's wherever the edema goes and whatever gets squished. So I suppose that means the symptoms it's like an anoxic brain injury almost. It's like you really just can't predict what's going to happen until you see it. And then you treat what you see in front of you, and then you manage the symptoms until the body can get through this medical insult, really.
Yeah.
Catherine, I see you. I'm looking at the article that you posted here.
Oh, yeah. Yeah. Nothing to concern you for now, but it just is interesting that just came out recently.
Just a few days ago. Like
yeah.
Ago.
Yeah.
Oh, man.
So,
right in our hometown, too. Adam, you and I also, I think, have bonded over Twitter because we both kind of get fired up over a lot of similar, I think, types of causes and things like that. We were recently just sharing a video of a, baggage handler tossing a custom wheelchair frame around like it was, a piece of garbage, things like that. You seem to have a heart for the underserved and unheard and things like that. That's what I see when I kind of scroll through your feed. Tell us, I guess, how does that?
It's an interesting Twitter feed.
It is. I mean, it's a little bit of 49ers things, and then so you bounce back and forth. You keep it interesting. I guess talk a little bit, if you would, about that aspect of your care, or how does that come into your care? Because this is, and I've talked with, when I interviewed Dan Steventon, who may be one of the best human beings on the planet, about the emotional load of dealing with cancer patients that it can be. But how does that maybe tie in or affect your day to day and things like that?
I think it just gives you a lot of perspective, right? Like early on in my career, I kind of got sucked into that. Like, you look at the patient in the bed, and if they are around your same age, I got a couple of kids at home, they've got a couple of kids at home, you start to think that could very easily be me. And so, working in oncology, we kind of get to see the best sides of things when patients do really well, and, we kind of get them to whatever that next big life milestone is for them. And we get to, we do what we can to help them get there from the physical side of things. But we also see a lot of really bad things. Treatments don't go well. Patients don't respond to treatments. Patients are going home on hospice knowing that they don't have a lot of time left, or going on comfort care while they're still in the hospital and are, passing quickly. And so it just gives you it makes you realize how important all the little things are, kind of not getting frustrated when, my toddler wants to take 15 minutes to put his own shoes on, even though no one has taught him how to put his shoes on or what feet they go on. It just brings a lot of perspective to your life to enjoy the little moments. And, we got Thanksgiving coming up in a couple of days as of the time that we're recording this. And, being home with family and healthy and being able to enjoy all of those things. And, we see, like I said, we see a lot of situations that don't go that way. And it took me a long time to figure out how to leave that at work and not kind of bring it all home with me, and, find ways to decompress and compartmentalize things. But yeah, it's hard. It's probably one of the hardest parts of the job. It is, I think, one of the hardest entry points for new grads getting into it is, especially on the acute care side. I share this story when I have students, as a CI, and my first week as a student on the BMT unit at Stanford, we lost 2 patients. And I called our clinical coordinator and was like, hey, I don't think this is for me. And luckily, they kind of told me, hey, stick it out, talk to your CI about it. My CI was fantastic. They could talk. And so it's a story that I share because, like I said, the emotional toll of it can start leaking into your work life, your personal life, so it can kind of eat at you if you don't find a way to deal with it. And like I said, kind of compartmentalize and be able to put it away and go home and enjoy, the kids and the dog and
Yeah.
everything else.
I think dealing with it in a healthy way is key. It's probably easy to find unhealthy ways of dealing with some of that stuff. Yeah, and I think, wow, as a student, the fact that students probably so rarely experience a patient death anyway, and the fact that you dealt with 2 in a week it's got to be huge. I can't imagine, having my students go through that and what that would be, how they would process that. That's, again, something that I had a similar experience, not to that degree, but a patient, my last clinical rotation was at a hospital that had a large burn center. And so we worked with, kind of similar to how you got tossed into working on the oncology unit. My CI happened to be one of the PTs who went to the burn center. So I went to the burn center too, and working with a patient who was so badly burned in a mobile home fire. And then we worked with this, and she was a teenage girl. Worked with her for I think most of my rotation there, which would have been about 9 or 10 weeks. And she was finally progressing and doing really well. And then a couple weeks after I was done, my CI just texted me that this patient threw a clot and died, after all this time that we'd worked. And it was so shocking. And so like, but we worked so hard, and she had come so far, and, we were doing all the right things. And it's just one of those things you can't predict, but that's life in the clinic. And that's something that I don't think we do a very good job of prepping people for, from an employment side.
Yeah. So, kind of thinking about that, right? Like working in cancer care, sometimes we have an idea that things aren't heading the right direction, and our docs have a pretty good idea of like, this is how much time they have left. And it gives you that little bit of time to prepare for it. But the story that I shared on Twitter that I think was the jumping off point for you asking me to come on here is when you're working with a patient and they're on your list one day and it didn't really seem like anything was too terribly wrong. And then you come back in the next day and they're gone. And those are the ones that really kind of take you back. Like you take a step back and you're like, what the hell just happened? So that happened to me a couple weeks ago. A young guy, 25 years old, was recovering from an allogeneic stem cell transplant. Things were going well. He's got a young kid at home. We're kind of getting him ready. We're probably like a week and a half away from potential discharge, and worked with him on Monday, and he coded that night, and they weren't able to resuscitate him. And so like, it's things like that, like we were just talking about, like, how do you handle that in a healthy manner? And then, you come in first thing in the morning the next day and you hear this news, and it's like, how do you get through the rest of your workday? How do you not let this affect you?
Yeah.
How do you move forward from that?
Yeah. Now let's have a department meeting about productivity standards or something like, some BS like that. Yeah. Oy. Catherine, you were going to say something earlier?
I was. Oh, yes. I think a lot of times in PT, we like to feel like we have some control, or like things are going to follow this predictable pattern and we're working hard towards our goals and stuff. And yeah, I can just imagine that would be hard the lack of control would be hard. There's so many variables that you can do your best, but there are some things that you can't influence or change no matter how hard you try.
Yeah. And I think that's something that at least my CI instilled in me early on, and something that I try to instill in students that I have early on, is that, you can have two patients that are, roughly the same age, that are in roughly the same shape, that have the same disease, that are going through the same treatment protocol, and have two wildly different outcomes. And there's nothing you can do about it. Like, that's so outside of your control, and we do what we can to help the patients that we can, and that's it. That's all you can do.
And that's so hard for patients, for not for patients, but for, I don't want to even just say students, I think clinicians, to be able to differentiate between the factors of patient care they can affect and the things they can't. So I use almost that exact same analogy when I talk about TBI rehab. Like, you could have two people get into, somehow duplicate the exact same car accident to give them the same mechanism of injury, and have completely different clinical presentations and functional impairments and needs and things like that. And it's like, we can't change that. All we can do is see what's in front of us and work with it. And I think that's very hard, especially if you're the kind of person who you want a protocol, you want to, this is, if this, then this, if this, then this, because it doesn't sound like in oncology it always works that way. And that's,
and right. And like, as regimented as things are, right? Like, we have in the ortho world, right? You have all of these CPGs, and, you know, you have this injury, you have this surgery, this is what we do, and this is the timeline for how things are going to get better. And there's no clinical practice guidelines for this patient population. It's just, you know, treat what you see. I try to, you know, keep things as simple as I can when patients are in the hospital. So probably the average length of stay for one of my patients, it's either like newly diagnosed that's coming in to start chemo, or our patients that are coming in for a stem cell transplant. I usually have them for around 3 to 4 weeks. And so we get to know our patients really well. You know, we chat a lot while we're working together. So, you know, we learn about their family and where they grew up, and, you know, kind of what their dreams are, what their hopes are for treatment, especially for our patients that are going through like clinical trial stuff. And it's like, what's keeping you motivated? Why are you continuing to, you know, you failed all of these other treatments that are, you know, standards, and now we're on to clinical trials. Like, what keeps you going? What is important to you? And I think out of all of the little niches of PT, I think we really get the most like patient-centered care, right? Like, what is important to you? Because you are going through this awful thing in your life. What's going to keep you motivated to want to work with me when I come in at 9 o'clock the next morning after you spent all night puking your guts up because you started a new chemo yesterday?
Yeah. And they see you coming through the door. All right, time to get moved. And they just flip you off.
The number of happy faces that I see before noon, I can probably count on one hand.
But I think it's a great thing that you bring up is recognizing those factors of patient care, of just the fact that, your patients may have had a terrible night because of some medical procedure, like it is an oncology medication maybe, but yes, it's wrecking their body, and recognizing that, we got to get through PT, but you're not going to go in there with the same protocol for the same patient every time, because if you do that, you're going to get things thrown at you, and you're not going to get good results from your interventions. But if you can recognize, like, oh, hey, Mr. Smith, looks like you didn't have a very good night. How you doing? Like, what can we do to get your stomach settled and get you feeling better? Because like that attitude, all of a sudden, they see you as someone who's trying to help instead of someone who's doing their job despite me, or whatever it is.
Yes. Yeah. So 2 questions that I always ask my patients, especially the ones that I usually check on in the morning, is, how was your night and what do you want to do today? Like, let's keep this as simple as possible. If you had a rough night and you're still just dry heaving, you can't keep anything down, who wants to go walk laps around the unit, or, go sit on the stationary bike for 15 minutes? Do you want to sit up in the chair? Do you want to lay in bed and let me stretch you out? So, I think it's a lot of what we do is really patient directed, because if you go in there, right, just guns blazing, this is what I've got planned for us today. It's like, you can take that right out of my room.
Yeah, exactly.
So my personal experience with oncology rehab was actually when I was in PT school. My grandfather was on hospice, and I went to visit him like during Christmas break, like stayed with them. He was at home for about a week, and he didn't have any PT coming in. But you could just, so he had mesothelioma and the tumor had grown enough. So that was affecting like the nerves in his back. So you could just tell he was in a lot of pain. He was really weak. And it was a terrible experience in many ways, but I was also like so glad that I was there, because even just like I wasn't doing anything crazy. I was just like doing passive range of motion and some stretches and like things that would make him feel good, or like doing some med mobility when no one else there knew how to like help him move. But that really, what you're saying really resonates with me with that of like, I didn't know what to do for a patient like that, but I was just like, okay, this is my grandpa. I want to make him feel better. Like, what can I do? And I think that takes you a long way.
And it's almost like a little bit of common sense. Like, well, hey, Grandpa, what would feel good right now? You know?
Right. And I think that's one of the neat things is that we get to be kind of the bright spot in some patient states when, it just feels like they're, pushing the boulder up the hill, and then they get another dose of chemo and that boulder rolls right back down to the bottom. And so we get to be, kind of that driving force, hey, let's get up, let's get up and do something today. I always tell my patients, a little bit of something is better than nothing, especially when they're stuck in the hospital for days or weeks at a time. You got to do something every day. Like if it's sitting up, if all you can manage is sitting up at the side of the bed, like that's something, but I can't just let you lay on your back 24 hours a day. Like that doesn't do either of us any good.
Yeah. Ooh, good stuff. Good stuff. I wanted to, sorry, I got a weird text message from my coworker. Jonas Brothers are playing in town tonight, and you wouldn't believe how many of my students were going. A lot.
That's funny.
Yeah.
The Joe Bros.
The Joe Bros. So, Leah, if you're listening to this episode, I hope it went well. She had a first date. Anyway. So,
a first date at the Jonas Brothers?
I know.
That's a big
swing.
I know, but it sounds like she was telling me, she's going to hate this is a podcast, but whatever, that she was a huge Jonas Brothers fan as a kid. So I was like, well, even if the date kind of stinks, you're still going to see, the Jonas Brothers that you love. So
my standards for first dates, Andy. If you don't die, it went well.
I feel like we got to work on that, Catherine. Anyhow, Adam, you talked earlier in the episode about the lack of oncology and PT education in DPT programs. And as a current faculty member in a DPT program, I can attest. Yeah, I don't think we got a lot in there. No, I don't teach any of the acute care or cardiopulm curriculum. So, which is where honestly it would probably live in our program if I'm thinking about it. So I can't speak to it with 100% certainty, but I don't think we got a lot of stuff going on there. So how do we fix this issue? Because it is now we have, through ABPTS, we have an oncology board certification. Like it's a thing.
Yeah.
Why it's a thing, but we don't teach it. So how do we make it a thing that we teach?
That's a great question. And I think we've had the same workshop at CSM for the last 3 years of like, how do we fit this into the curriculum? Like, right. The programs are long enough. Like we're not going to be able to shoehorn a whole another class in there. There
should have been an ELC. That was a huge topic of conversation of just curricular creep.
Yeah.
Cramming stuff in. We don't take anything out.
Yeah. I think probably the easiest way is that if you are in a program that offers like an elective, get somebody in there that's willing to teach it as an elective, because even if it's a handful of students that are interested in it, giving them that exposure to it is going to help them kind of figure out if that's what they want to do. If they're getting that exposure early, they may seek out a clinical rotation where they get to work with this patient population.
Yeah.
But yeah, I think it's tough because it encompasses a lot. I think, that's, we were talking about that earlier too, is that, it's sprinkled throughout everything. We get the cardiopulm stuff. We get the neuro stuff. We get, all the big GI surgeries. We get musculoskeletal stuff. So it's something that I think can probably be, kind of sprinkled around in the other courses that are already being taught, but it needs to be talked about. So if I can throw some numbers at you.
Do
So
it. Love numbers.
the NCI is predicting in 2023, 1.9 million new cancer diagnoses. So we need to be able to treat these things. We need to know how to safely manage these patients, because we don't have that education, that background, right? Like, I think our exposure to oncology when I was in PT school was, part of a pathophysiology lecture. And most of it was, here are the red flags, you refer them back to the physician.
Oh my gosh.
That is it.
That's exactly it. It was like, here are the red flags. If it's this, don't touch it with a 10-foot pole and send him to the doctor. Oh my gosh. I had a continuing ed course. Oh my gosh. I had a continuing ed course that was all about like differential diagnosis. And I still have the manual because 90% of it was red flag, refer out, red flag, refer out. It's terrible.
They have night sweats and a weird pain that you can't figure out where it's going to send them right back to their doctor.
Run screaming. Oh my gosh.
And then the other number that I wanted to throw out was they looked at predicting out into the future. So they're predicting by 2032, there can be as many as 22.5 million cancer survivors living in the US. So regardless of what kind of clinic you work in, whether you're in outpatient, whether you're an inpatient, whether you're an ortho, whether you're a neuro, you are going to come across somebody that is either has survived a cancer diagnosis and the treatment that comes along with it, or you're going to have a patient that comes in because they have a weird shoulder injury, but then you find out that they're also actively going through treatment for something else. And we need to know how what they're going through or have been through affect our clinical decision-making. What kinds of side effects come along with the treatments that they're going through. So like, you look at how many new cases of breast cancer there are a year. I don't have the number in front of me, but it's pretty high. But, the treatments that these women are going through can cause all kinds of other issues. We can end up with avascular necrosis in their hip that's causing them pain, that's limiting their ability to do ADLs or recreational activities. So they come to your outpatient clinic because their hip hurts. But if you have no idea why that should even be on your list of things to ask about, right? Because, you start mobilizing things and strengthening things and cranking on their leg, and now they have a femur fracture.
Crunch. Yeah.
Andy's familiar with causing fractures in patients. So
we're going to do this, Catherine. We're going to do this right now.
No, we just did it on the last episode. That's an Easter egg. Go to the last episode.
Go back in our thread and find out how. And I wanted to bring up, since you were tossing some numbers, that this reminded me, because I feel like Dan Stevenson told me some numbers as well, that the survivability rates for cancer are increasing significantly. If I remember what he told me, that it's much more survivable than it was, even 10, 20 years ago. But I think he also tossed out something, and you kind of hinted at this, that the vast majority, and I want to say 90%, but I feel like now that I'm saying that it's wrong, but the vast majority of cancer survivors will have some chronic medical condition as a result. So yeah, it's almost like it's not an if you treat a cancer survivor or a cancer patient, it's when.
Yeah.
You may have already, and you just didn't know it.
Yeah, exactly. No, I don't think that number is 90%, but it's up there. And so, especially, right, like talking to Dan, you get these peds patients that now are having either issues later on in adulthood or having a secondary cancer that's caused by the treatments they went through as a kid. And so,
insult to injury right there.
The gift that keeps on giving.
I work in pelvic health, which, I mean, you see, that's when you're talking about niches within niches. So like the onco pelvic health is like a whole thing.
If you haven't had Alex Hill on yet, you need to have Alex Hill on to talk about.
She's on the list.
Yes, she is.
She's a rock star.
I've heard her talk a couple of times, and I took a course with her once. She's awesome. But
nice. Well, send her an email, Catherine. Come on.
Oh, Ryan, I think I do have her email.
I'll tell her she needs to talk to you.
Okay, cool.
Awesome. What was I saying? Oh, so I specifically work a lot with kids who have pelvic health issues too. And it's not uncommon for kids who've had some kind of abdominal surgery or pelvic surgery to then have like lasting bowel and bladder issues that may or may not have been related to like the original reason they had that. So yeah, it's everywhere is basically what I'm saying.
Yeah, it's a weird phenomenon that we have with our like leukemia and lymphoma patients where like their treatment for their lymphoma cures their lymphoma, but then down the road causes them to have a leukemia. And so, yeah,
How common
right,
is that? I'm just curious.
I don't have stats for you,
Right,
but
that wasn't
like,
fair of me.
Just anecdotally, I would say, from what I've seen, probably 5 to 10% of our lymphoma patients will develop a secondary cancer.
That's a significant number.
And that's just from, the number of patients that I've treated. That's not.
So, all right. What else do you want to talk about, Adam? Because you even said you were an open book. So we got soapboxes on soapboxes, so we can stack them high. What do you want? What else do you want to talk about?
I mean, we got to talk about my first soapbox already, which is just the lack of education. And for so many reasons, right? Like we talked about, you're most likely going to treat somebody that has had or will have cancer. So we need to know what to do.
To be known.
Yeah. I think my other big soapbox is just, you look at the amount of money that is spent on cancer research, and we still have all of these like weird niches of underserved areas. So you look at like less than 4% of all cancer research funding goes to pediatric cancers. And so that's a huge dollar amount that's being spent on cancer research. And less than 4% of it is going to pediatric cancers, where as treatments continue to improve, right, we can improve the lifespan of these kids that are going through treatments. We can increase support and resources for families, for parents, for caregivers that are taking care of their kids when they're going through this horrific thing. You look at the lack of like long-term survivorship clinics. You look at, how much money is being put into social determinants of health and how they affect long-term cancer survivorship. We look at the lack of funding for stage 4 and terminal cancers. They're just kind of written off. We have these couple of treatment options for you, but your cancer's already way out of control and there's probably not anything we can do for you. So you have all these weird, kind of pockets of patients that, there's all of this attention, right? We have the big cancer moonshot coming out of the White House. There's all of this funding, but it's not distributed equitably.
Interesting. And that's not something that ever makes the news. Yeah. They talk about the fact, we're funding cancer research. Fantastic. No one's going to oppose that. But then you don't dig into a little bit more to realize like, well, okay, yes, that's great. But, there are so many people even within that population who won't benefit from it. And how can you spread that wealth out a little more evenly? Yeah, it's interesting.
I have a question that's somewhat tangential, but I'm assuming that you probably have a decent number of people that maybe ask about like alternative things in the cancer world, like in pelvic health, gut health, autoimmune stuff. There's a lot of like, crystals and like, do I need to travel to Mexico stuff coming at you? And I guess I'm just curious about your experience with that and how you handle it.
That is definitely one of those things that I will refer right back to their doctor. It's like, have you heard about these mushrooms that you can eat that are supposed to help with your inflammatory markers? And like, I can have one of the dietitians or your doctor stop by to chat with you about your mushrooms, but that's not something I'm talking about today.
Yes, you could always pull out I'm allergic to mushrooms. All right, what are you going to do?
No, we had a patient 5-6 years ago that came in, new diagnosis of acute leukemia, had started treatment, was actually responding pretty well. And then like we find out months later that he comes back into his oncologist clinic after no showing for several appointments. And comes back and he's really sick, and his doctor asks him, like, what happened? Why did you fall off? Like, you stopped coming in, we couldn't get a hold of you. And he went down to Mexico and like looked into these alternative treatments and came back, and his cancer was to the point where it's like we're out of options. Like, we don't have anything that we can do now. Like, it's spread to all of your organs. It's too late now. And those are the stories. And it's like, you look at, I know misinformation is a big buzzword lately, but we have non-reputable sources that patients are finding this information because they just type in their diagnosis into Google, and whatever pops up that's, not this horrendous chemotherapy regimen that their doctor just told them out. They're like, oh, like maybe I'll try this. It doesn't seem as bad. And it's just such a weird rabbit hole to go down.
And it's got to be hard to be. I would feel if I was the clinician, it would be hard for me to withhold judgment. It would be like, well, you wasted your time, you wasted this opportunity, but also think about from their perspective of they're trying desperately to find anything that will work. And so it's like, it's easy to judge what from me in my not cancer having state, What if I was there in the weeds and just like, I don't know what to do, and someone offers me what might be a lifeline, I can see why they would do it, and so it's like, it sucks. Especially when like you just said, like the time that you spent doing this closed the window of opportunity for these other proven methods or, whatever. Yeah. That's going to be hard.
Yeah. And I think, something that you just kind of touched on is like, it's really easy for me to kind of sit here and be like, what the hell were you thinking? When I'm not the one that's dealing with it. Like,
yeah, exactly.
I'm not the one that just got this life-changing diagnosis. Patients are scared, right? Like Dr. Google, there's so much information out there, and it's hard to sift through the good stuff from the bad stuff. And I think those are important talks that need to be had early on when a patient is getting this new diagnosis. Give them time to process, but don't give them too much time to do too much of their own research, right?
Yeah.
And depending on your previous experiences with healthcare and or if you're a minority or some other group that, has legitimate reasons to maybe question or mistrust the establishment.
Yeah, for sure.
I mean, I could see how you would get there.
Yeah.
So, Adam, how do we get students excited about working in Oncologic PT?
I think a lot of it is exposure. Like, we need to show them what's out there. Like I said, we get to make a really big difference in people's lives when they're going through the darkest time of their life. And so, right, like whether that is getting someone that's going through treatment back to the things that they were doing before, or making sure that that 70-year-old patient that just finished their last round of chemo and is not showing response to disease and knows that maybe their time is limited, making sure that they can do the things that they enjoy doing, being able to go for a walk with their dog, being able to get up and down off the floor to play with their grandkids. Like there is a lot more, this is where I get a little bit cynical, having spent a little bit of time in outpatient ortho. And it's like, what I do now, like, don't get me wrong, every PT that is working, that is, there for their patients is doing incredible work. But I feel like I have such a bigger impact on somebody's life when they're going through chemo, when they're going through a stem cell transplant, when they're getting ready to go home on hospice and asking me, what can I still do? When the family's asking me, what can we do for them to keep them comfortable, keep them moving? Like, that gets me way more excited than, like, I've helped Bob get back to golfing 3 times a week. Like, that just doesn't do it for me.
But it does for some people, and that's great.
It does.
I'm glad those people are there that do it.
And we need those people.
Need those people. But I hear what you're saying. This is Yeah. Not that we don't want to say like the stakes are higher, but because that's maybe not fair. But yes, I think for certain clinicians, like, yeah, that's where we get excited to do what we do.
Right? Like you look at your work that you do with or did with TBI patients, and it's like, their functional recovery, they're probably not getting back to 100% of what they were doing before, but we can still make a really meaningful impact on what they can do.
As a student, I never would have said I ever wanted to work in TBI rehab. And as a clinician, I couldn't imagine working anywhere else. Just that was my jam. Those are my people. Those Rancho 4s.
You never know.
Those are my people.
Where your career's going to take you.
I know.
No, and so that comes back to, right, like we need that exposure. We need that exposure to things like being a PT in the emergency department. We need that exposure to working in small community healthcare clinics. Like, it's not all sports med and,
Were you that student, Adam, when you went to PT school like the rest of us?
Oh, yeah.
Yeah.
Yep. Right. I was a broken former athlete that started as an athletic training major and then got tired of working with athletes all the time because they're prima donnas and terrible patients. I was like, what else is out there?
Waves podcast does not discriminate against sports clinical specialists. We think you're also doing very good work out there.
Oh my God.
But yes, I think
athletes get cancer too. Athletes have brain injuries too.
I do remember. I want to say it was John Kruk who played for the Phillies back with like Lenny Dykstra back in that era. I need to, before I even tell the story, I need to like look it up here because now watch, I'm going to completely say the wrong thing.
Well, you're looking that up, right? We talk about athletes getting cancer, right? You look at Eric Berry in the NFL who went through a lymphoma diagnosis and, was able to get back to playing at a very high level. And you think about, right, like the treatment that he went through and the side effects, right? Like the potential for neuropathies and things like that. You take someone that was at the peak of their athletic career and now give them this diagnosis and put them through this treatment that there's a risk that you are never going to get to do that again. And that's, I can't even imagine hearing that news and an athlete who is probably in the best shape of their life and it's like, oh, hey, you have cancer. Like,
so I was correct. John Kruk, who used to play for the Phillies, in 1994 in spring training, he was playing first base and they tried to do a pickoff throw and it was a bad throw and it hit him in the cup and broke it and caused him some severe distress and pain. And in getting checked for that injury, it was when they discovered he had testicular cancer. So had he not gotten hit in the cup, they might not have caught it. So,
right. Like there is so many weird stories that we hear from patients. Like we had a patient that was putting their cart back at the grocery store and tripped over one of the little concrete parking curb things and broke her leg. And they found out that the reason that her leg snapped so easily is because she had multiple myeloma and it was in her bones. And had they not caught that, like when they did, myeloma spreads to the spine, can cause all kinds of issues. So, the number of patients that I've had that either like routine physical found something in their blood work or like felt a little bit more fatigued after going for a hike than they normally do. And they weren't recovering. So they decided to go see their PCP and their PCP was like, yeah, we should probably get this checked out, and found out that they had leukemia. And the reason that they were super fatigued is because their counts were all out of whack. And like, we hear those stories all the time, just like weird, random things that people look into. And it's like, now you have this life-changing diagnosis and how do you cope with that and move on? And it's hard.
That's why all the decision algorithms are refer out. Could be.
Oh my gosh. I feel like we need to have the title of this episode should be Refer Out? No. Maybe not. We'll workshop that one. We'll workshop that one. Adam, thank you so much for spending a little bit of your evening with us talking about oncology, physical therapy, and all the awesome work that you do out there in the lovely Bay Area of California.
Thanks for having me. It was a pleasure.
Nice talking with you, Adam.
Waves is a production of APTA Michigan. It is co-hosted by Dr. Catherine Klein and me, Andy Wicks. Editing help today from Brigit Hammond. Dr. Adam Matichak is a board-certified oncologic clinical specialist in California. Despite what you may hear later, cool people, like Adam, name their cool dogs Lando because it's a cool name. Waves can be found on our website, www.aptami.org/podcasts, or on social media at APTAMIWaves. You can, of course, find and subscribe to Waves wherever you get your podcasts. And don't forget to check out the show notes to see how you can earn PDR credits towards license renewal just by listening to Waves episodes if you are a PT or PTA in Michigan. As always, thank you for listening, and may your documentation always be done on time.
Here's my buddy.
Oh,
He's got to sit in his little cage or he'll be in my lap.
oh yeah. What's your dog's name?
Lando.
Oh, nice.
Yeah. His birthday's May 4th, so he needed a Star Wars name for his birthday.
I was going to ask if that was a Star Wars reference.
Yeah.
Of course it's a Star Wars reference, Catherine. People don't name their dogs Lando because it's a cool name.
I don't know.
Cool name
Maybe
and it's
some
in Star
people
Wars.
do. Maybe some people do.
My goodness, we're off to a great start already.
Who am I to say that no one names their animal Lando for any other reason besides Star Wars?
I have a Star Wars joke. My son Luke loves that we named him after a Star Wars character. But my daughter Chewbacca, not so much.
Oh my God.